Hey guys, this is video number 2 of the upper extremity. This video will be covering primarily the rotator cuff muscles. You can see them here, these 4 rotator cuff muscles. We'll also be looking at the glenohumeral joint. I'll also go over, before we do that, go over some of the bony landmarks you'll need to know for where these muscles attach to. So let's jump in. First, what we're going to be covering today is we're going to be talking about 4 rotator cuff muscles: the supraspinatus, the infraspinatus, the teres minor, and there's also one more on the front that you can't see very well called the subscapularis. So those are the 4 muscles. The subscap is beneath your pec major, underneath here, sitting right on the scapula. The 4 rotator cuff muscles, guys, are here. This is my right shoulder. So you see the subscapularis on the front, the supraspinatus on top, and the other 2, the infraspinatus and teres minor on the back. Those are the 4 we're going to talk about today. This is my dorky little wrap for the muscles we're going to be talking about this unit. Muscles of the shoulder help you move a boulder. 4 lock your humerus down. 1 pushes you off the ground. Bully moves humerus all around. Mirror image and twins pulling scapula back. 8 in all to keep you on track. Pretty dorky. Today we're going to be talking about these 4 that lock your humerus down. Tomorrow we'll talk about 1 here, 1 here, 1 here, and 2 there, and those are the other 4. So for the next class we'll talk about those other 4. And that's the 8 muscles of the shoulder that we'll cover. I've ignored some. This you guys will get in class, not in color unfortunately, because I can't print in color very easily anymore. But I will have this posted online so you guys have it as a PDF. Again, we're going to be covering these top 4 today, and we're going to be covering these next 4 the following class. And we will have you guys know, I will have you guys know the origin, insertion, and all the actions of these muscles. So one of the hardest parts of this unit is all of the bony landmarkings. So to make sure I talk about the bones that are involved in the muscles we're building, and the landmarks on the bones I want you guys to know. So for today, for these 4 rotator cuff muscles, the bony landmarkings can be seen here. This area where the supraspinatus sits inside of is called the supraspinous fossa. It is this big valley up top on the superior portion of your scapula that muscle sits right inside of. So supraspinous fossa. There's also the infraspinous fossa. This is the spine of my scapula right here. So above the spine is the supraspinous fossa. Below, or infra, is the infraspinous fossa. To the side, you have the lateral or axial border. So this is the lateral axial border, and one of the muscles will originate there. So here's one origin today is supraspinous fossa, infraspinous fossa, axial border of the scapula. Those are all origins. Another origin is on the front side, is this subscapular fossa right here. Those aren't so bad because they're mostly named after the muscles that sit inside them, so those won't be as bad to memorize. And the 2 landmarks I want you guys to know on the humerus are right here. There is a greater tubercle where there's actually 3 insertion sites. So that greater tubercle is on the outside, the lateral part of the humerus, and there's actually 3 muscles that attach, that insert onto that greater tubercle. And on the front side, you have a smaller hill. So between this hill, you have a little valley. And you have another hill called your lesser tubercle, and that's on the front, the anterior portion. And that's the other bony landmark you guys need to know. So 3 fossas, 1, 2, 3, 1 border, and then 2 tubercles. And that's where all the origins and insertions come from for today's muscles. So jumping into the first muscle, we're talking about the supraspinatus. This is the first muscle we'll build tomorrow. The supraspinatus is one of the most commonly injured muscles, honestly, in your body, especially for overhead throwing athletes. The supraspinatus, again looking at this muscle, is on top. It is above the spine of the scapula. It sits in the supraspinous fossa. So the supraspinous fossa is where this muscle originates. So this big fleshy attachment originates in the supraspinous fossa, and it inserts down onto the superior third of the greater tubercle. This top third is right where that supraspinatus inserts onto. So origin, insertion. And you guys can imagine with me, if this thing were to pull, contract, and get shorter, the humerus will go straight out to the side. So as my supraspinatus, which is right here, pulls on my humerus and gets shorter, it pulls my arm up into abduction. And that's what you see right here on the slide, is abduction. And just like all of the rotator cuff muscles, it stabilizes the humeral head. So as I throw things, as I'm throwing my arm around, these rotator cuff muscles secure or lock the humeral head. So if I ever do this in class, I'm talking about stabilization stabilizing the humeral head or securing the humeral head. So those are the two main functions. And importantly, if someone is pushing my arm down, the muscle resisting that, there's a couple of them, but as my arm is adducting, as it is being pushed down, I'm trying to resist it, that supraspinatus is lengthening. So it abducts concentrically as it shortens, and it resists adduction eccentrically as it lengthens. I would play that a couple times. Concentric abduction, eccentric adduction. It kind of slows down adduction as it lengthens eccentrically. So that's the supraspinatus, again, really commonly injured muscle. Another one is the infraspinatus, right below the spine of the scapula. So supraspinatus above, infraspinatus below is right here is this guy. This infraspinatus has a fleshy origin on this infraspinous fossa. This big red guy is where it originates in the infraspinous fossa. It inserts onto the middle third of the greater tubercle. So that's what you guys see right here. The middle third of the greater tubercle is the insertion point. So origin, infraspinous fossa, insertion, middle third of the greater tubercle of the humerus. And what it does, since it's on the backside of my scapula here, as it contracts and gets shorter, my arm, as it contracts and gets shorter on the backside, it pulls my arm into external rotation. So it externally rotates concentrically. It resists internal rotation eccentrically as it lengthens. And just like all the rotator cuff muscles, it locks or secures the humeral head. So this is probably the most important of all of the things on the screen, is on the backside, this infraspinatus, since it's on the back, it concentrically externally rotates. It eccentrically resists internal rotation the opposite way, and it locks in that humerus, so it stabilizes it. Okay, so that is the infraspinatus. Again, we're going to build all these muscles tomorrow in class. Okay, next one, guys, is the teres minor. It has exactly the same functions as the infraspinatus, since they're right by each other. The infraspinatus originates here, inserts there. The teres minor originates here on the axial border of the scapula and inserts onto the inferior third of the greater tubercle. So that's where it inserts onto. So origin, insertion. It does the same thing. It is behind, so it concentrically externally rotates, eccentrically internally rotates, and stabilizes the humeral head. Okay, last one, guys, last muscle of the four. This is going to be the last one we're going to build tomorrow. The hardest one to build on your mannequin, because we have to disassemble the shoulder to do it. This subscapularis, guys, is not on the back side where the spine of the scapula is. You can actually feel your spine of the scapula. You walk your hand down. This is actually on the front side. So beneath my pec major, deep down, embedded on my subscapular fossa, is my subscapularis. So a big fleshy attachment here on the subscapular fossa, right here. It goes over and inserts onto the, the lesser tubercle right here of the humerus. So originate on the subscapular fossa, inserts onto the lesser tubercle of the humerus. And I want you guys to pause the video and actually think about what motions would this produce without looking at this slide either. So pause the video. And since the subscapularis, guys, is on the front, attached to this lesser tubercle on the front, you can actually feel that bump a little bit right here. So the lesser tubercle. It is, when it concentrically pulls, it pulls my arm into internal rotation, and when it shortens concentrically, it pulls my arm into internal rotation. That's the main thing it does. When someone's pushing on my arm outward, it is resisting the opposite motion eccentrically. And guys, pretty soon I'm going to have you guys expect you guys to know this. It will always resist eccentrically the opposite of whatever action you see there. So internal rotation concentrically, it resists the opposite external rotation eccentrically. And of course, it stabilizes the humeral head. So that's the subscapularis. I would pause the video here, guys, and using this slide, kind of quiz yourself on the origin, insertion, action of the supraspinatus, infraspinatus, teres minor, and subscapularis. These are the first four muscles that you have to know for this unit. We're going to know 16 total, 8 for the shoulder, 8 for the forearm and hand. So pause the video, quiz yourself. Okay, next one, guys, is injuries. Injuries of the rotator cuff. There's many of them. Rachel Yurkovich was an athlete I went to school with at U of O. She was a national champion javelin thrower. She threw 194 feet, I think, in the javelin. She wasn't very big. She wasn't hugely muscular, but she was very, very strong. She was very, very athletic, very hardworking. So she was a javelin thrower, and she had shoulder problems. So I want you guys to think real quick, which movements get her right glenohumeral joint into this position? So what movements occur at that joint for that to happen? Which rotator cuff muscles were involved in producing those movements? Which rotator cuff muscles will contract over the next second to get her out of that position as she moves into this position? Which ones will be involved in having her move out of that position? And which rotator cuff muscles will eccentrically lengthen to slow her humerus once she's thrown that javelin? So this is some complex stuff. So let me think through this with you. So on this first slide, we say which movements have occurred to get her right shoulder into this mess. So think with me. I'm a lefty. As I raise my arm up, I'm going to basically abduct my arm. Maybe I'll do a little bit of hyperflexion. If my glenohumeral joint is flexion, extension, I have to kind of abduct and pretty much hyperflex back. So a little bit of abduction, hyperflexion. And my arm, which is rotating this way, is doing the same thing as if it was rotating out. So it's external rotation. So I would say abduction, hyperflexion, and then external rotation as my shoulder externally rotates out. That's what gets her arm in this crazy insecure position. So at the glenohumeral joint, let's write this down. At the glenohumeral joint, you find probably three primary movements. The first one, to get your arm up, is abduction. The next one, to move your arm back kind of behind your head, there's a little bit of hyperflexion going on as you're raising it up above. Again, flexion reduces the joint angle, hyperflexion kind of goes beyond. So flexion, 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 hyperflexion. But generally as we throw, we abduct to get there. So three, the last one, and this is important, is external rotation. A lot of the injuries happen because of the rotation of the shoulder, not necessarily the flexion of the shoulder. So external rotation. So those are three movements. Which rotator cuff muscles have produced these movements? So thinking about the supraspinatus is on the top of your arm. So as it concentrically contracts and gets shorter, the supraspinatus is involved in producing abduction. Right? So that's the one on top. My supraspinatus pulls and gets shorter, brings me up into abduction. None of these are really involved in flexion or hyperflexion. So the only other one for the rotator cuff would be the infraspinatus on the back and the teres minor on the back. And think about what action these produce. Both of these produce the same action concentrically of external rotation. Again, they're on the back side, and as these guys pull and get shorter, I'm pulled into external rotation. So both of those are involved in getting her into this incredibly unstable position that javelin throwers put themselves in voluntarily. So those are the rotator cuff muscles producing those movements. Which rotator cuff muscles will contract over the next seconds to get her out of this position? So I'm thinking about the opposite, guys, of these motions. So adduction, extension, internal rotation. And the only ones we've learned about so far would be the opposite of external rotation would be internal rotation. So what things produce internal rotation? And the only one we talked about for the rotator cuff was the subscapularis. So the subscapularis will be firing to get her out of this position. So her subscap right here on the front side of her shoulder are going to be firing to internally rotate her arm out of this javelin throw as she follows through. So subscapularis. Okay, and then the last one is which rotator cuff muscles will eccentrically lengthen to slow her humerus. So as she is throwing the javelin and she lets go of the javelin, she continues to do this motion of internal rotation. So she's in external rotation, going to internal rotation. So which muscles prevent internal rotation? It's all these ones on the back side. So the main ones to say would be infraspinatus, teres minor, and maybe a little bit of supraspinatus, but it's mainly these backside, these guys. So as she goes from external rotation into internal rotation, the backside muscles in my rotator cuff are eccentrically lengthening to slow that arm down. So which ones slow the humerus, and the main two are infraspinatus and the teres minor on the back, eccentrically slowing internal rotation. So bam. So that's, I think, one way, guys, you can think about a bunch of injuries to the rotator cuff happen with overhead athletes like javelin throwers. The same kind of thinking happens with volleyball players, with baseball pitchers, lots of overhead throwing athletes, quarterbacks, because of how much force is produced and how much energy has to go into slowing that humerus down on the backside. So a lot of injuries happen to the infraspinatus teres minor. A lot of injuries happen to the supraspinatus on the front as well. Okay, so that's the first couple injuries. That's the first injury I'm going to talk about. The next three, guys, are here. Impingement syndrome is really common for overhead athletes again, and for people who are just using their arm above their shoulders. My dad worked with a lot of elderly people who had impingement, and they couldn't really reach up and grab their dishes off from their cabinets. Also, rotator cuff tears, when you actually strain or tear, so partial or full tearing of the supraspinatus here. Also, there's some overuse tendinitis, that when you get this muscle tissue inflamed and irritated. So I would write these definitions down. Impingement is basically a pinching, most likely in your supraspinatus. It's basically a compression, guys, of this bursa, which is basically like an airbag or a water sac that kind of cushions muscles and joints. So this bursa gets pinched up against this acromion process of your scapula. So on my model, what this looks like is up on top, you have the supraspinatus muscle right here, and as you throw as an overhead athlete, this actually pinches up against this acromion process. So there's this subacromial space kind of goes away as soon as you raise your arm up into an overhead throwing motion, pinching this bursa and kind of grinding up against this acromion process on your scapula. Rotator cuff strain, I use strain because we sometimes say, oh, I had a muscle tear. A complete tear is a complete strain. So you can have a partial or a full strain. So I use strain and tear synonymously, as do athletic trainers. And that can happen with any rotator cuff tendon. Sometimes they'll use this tissue called a suture, this thread-like tissue, to actually pull back over and repair that torn tissue. We're going to watch a video on that in a second. Last one, guys, is overuse tendinitis. If you have chronic inflammation, you can always tell inflammation by the suffix itis. Itis in Latin just means inflamed or irritated. And when you have enough inflammation in your muscles, it can actually fray. The muscle tissue itself can actually fray up. The muscle fibers can peel up. So that's overuse tendinitis. Icing, ibuprofen are oftentimes treatments for tendinitis. Three more types, guys. I'm going to play some videos here. And I'm sorry for the length of the video. I'm going to play some videos. I'm just going to play these videos, and I'll play it through so you don't have to go look these videos up later. So this is the first injury.
The rotator cuff is a group of muscles and tendons that hold the shoulder joint in place and allow you to move your arm and shoulder.
Be identifying these muscles as the video plays.
The rotator cuff becomes irritated or damaged. This can result in pain, weakness, and reduced range of motion.
So muscle strain,
Sometimes
inflammation,
more tendons become detached from the bone.
complete strain, complete tear,
A surgeon can reattach the tendon to
suture,
the bone using a thread-like material called a suture. But sometimes the tendon is too badly damaged to be reattached. In that case, the surgeon may consider a tendon transfer. This is a procedure in which a tendon from a different location is used to repair the rotator cuff. The tendon most commonly transferred is the latissimus dorsi tendon in the back. For a latissimus dorsi transfer, the surgeon makes two incisions, one in the back and one in the front of the shoulder.
I think it's pretty cool.
In the back, the surgeon detaches one end of a latissimus dorsi tendon and attaches a suture to that end. In the front, the surgeon creates a flap in the deltoid muscle, which covers the shoulder. He or she inserts a tool to grasp the end of the latissimus dorsi tendon. The surgeon brings the tendon under the deltoid to its new position. Sutures are used to connect the transferred tendon to any remaining rotator cuff.
So bam, new supraspinatus.
The surgeon tightens the sutures to pull the tendon against the bone and ties it securely in place. In some cases, anchors are inserted into the bone to help hold the sutures in place. The surgeon closes the flap in the deltoid muscle. The incisions are then closed in the front and back.
So one way to think about that is your latissimus dorsi, your lat muscle, is a muscle that they can actually disengage from your humerus, pull back around, and use in the place of a rotator cuff muscle when the strain is bad enough or when the strain is medial enough. When you can't actually pull that supraspinatus back over and suture it, you can actually use just a different tendon to secure that humeral head. So what will lock that head down now is not your supraspinatus, but your latissimus dorsi, this big, broad muscle on the side of your body. And we're not going to actually cover that muscle, which is a little bit sad. But okay, next video, guys, is this one, an arthroscopic subacromial decompression.
The rotator
Again, quiz yourself on these muscles as the video plays.
Put the shoulder joint in place and allow you to move your arm and shoulder. Problems occur when part of the rotator cuff becomes irritated or damaged. This can result in pain, weakness, and reduced range of motion. Sometimes a bone spur forms on a shoulder bone called the
acromion process of your scapula.
Acromial refers to the space beneath this bone. A bone spur in this location irritates and frays the rotator cuff tendon directly underneath. To relieve pressure on the tendon, a decompression procedure may be performed. Often a surgeon can accomplish this with an arthroscopic procedure, inserting a camera and tools through small incisions. This operation is called an arthroscopic subacromial decompression. The surgeon grinds down the spur and smooths the bone. He or she may also clean the frayed portions of the tendon by shaving them.
Again, pretty neat. So again, the arthroscope just means that you can see it with a camera. Subacromial is that space between your acromion process and your supraspinatus. Decompression is the grinding away of bones. So sometimes people say, I want to decompress after work. Gives a whole new meaning to the word decompress, kind of shaving away, releasing the pressure from the bone. You can also get rid of that, the frayed muscle fibers on the supraspinatus. Okay, last video. This one is about a reverse shoulder replacement.
The rotator cuff is a group of muscles and tendons that hold the shoulder joint in place and allow you to move your arm and shoulder. Problems with the rotator cuff may cause weakness or pain and restrict movement. It may also cause damage to the shoulder joint. Often tendons can be repaired. However, if the tendons are severely damaged, an operation called
So this is pretty cool. This is your supraspinatus up here, if you guys see this. Your supraspinatus is frayed and torn, so it's fully strained, and your subscapularis on the front is also torn all the way through. I say cool because this is gruesome. This is absolutely gruesome. But if it's this bad, a normal shoulder replacement doesn't work. You need something different, because even if you get a new head in here, you don't have the muscles to secure that total shoulder. So if you can't just replace this humerus because you have no muscles to secure it.
Reverse shoulder replacement may be a better way to improve the joint's function and reduce pain, especially if the joint is affected by arthritis. This operation is also called reverse arthroplasty. Arthro means joint. Plasty means to mold surgically. The top of the arm bone fits into a socket on the shoulder blade. In a typical shoulder replacement, a plastic lining is attached to the socket to allow smooth movement. The surgeon removes the top of the arm bone and inserts a metal stem with a ball on the end. However, if the rotator cuff is severely damaged, the joint may not be stable or work properly. In a reverse shoulder replacement, the normal ball and socket structure is reversed. An artificial ball is attached to the shoulder blade. An artificial socket is attached to the top of the arm bone.
The humerus.
The large deltoid muscle that covers the shoulder is typically able to move the arm. General anesthesia will be given so you will sleep through the surgery. An incision or cut is made in the front of the arm and shoulder. The surgeon separates muscles and cuts through tissue to expose the joint. The upper arm bone is removed from the socket. The top of the arm bone is cut off and prepared to receive an artificial part. The socket is also prepared. A plate is screwed to the socket and a half sphere attached. The metal stem is inserted in the arm bone and a plastic socket is attached to the top. The new socket is fitted against the new ball to allow smooth movement. The tissue is sewn together around the joint and the incision is closed.
Yeah, I think that's really cool. What I expect you guys to know from that is that a reverse arthroplasty or reverse shoulder replacement is when there is enough muscle damage that you can't have the rotator cuff functioning to stabilize the humerus anymore. So you have to reverse the joint. You reverse where the ball and the socket are. And so the deltoid kind of takes over the stabilizing of that humerus. So you reverse the joint, deltoid takes over for the function of the rotator cuff. So I'd write that down. Okay, last thing, guys, I know it's getting longer, video, sorry, is the joint type of the day is the glenohumeral joint. This is the one most related to the rotator cuff, so this is going to be the joint I'm going to highlight today. The type we've already talked about is synovial, the most freely moving joint type in your body. The type of synovial joint is the most freely movable synovial joint, called a ball and socket joint. Just like your hip, provides a lot of mobility, a lot of flexibility, mobility, but there's low stability, so there's a lot of injuries to your ball and socket joint. The movements, this was a warm-up we did also. They allows you to flex and extend, flexion, hyperflexion, extension, hyperextension. Also allows you to abduct, hyperabduction, adduction, hyperadduction, internal rotation, external rotation, same thing here, internal rotation, external rotation, and also circumduction, which is a combination of a bunch of different motions. Guys, this joint, this glenohumeral joint, is the only articulation between two bones, your humerus and your scapula. So anything you do with your hand or elbows or arm, really all that force goes to this one joint. So this has to be an incredibly stable joint. And you find overhead athletes like javelin throwers, baseball pitchers, volleyball players have a lot of issues with this joint because they abuse it. They want to maximize the amount of force that goes through it. This joint is stabilized, guys, by a couple different structures. These are the ones I want you to know, and you might even be able to draw this out by hand. It's stabilized, guys, by the rotator cuff, those four muscles we talked about. It's also stabilized by the labrum. And the labrum, if I had to pick a picture to show the labrum, I don't know if I have that picture that I want. The labrum, guys, is on this picture. This labrum is this outside edge. It's almost like the cone of shame for a dog. It's like a slight cone of shame right around the lip of your glenoid fossa. So right around that valley where your humerus sits inside of, right around that lip, on that glenoid fossa, you have an extra little lip that extends out a little bit, and that's your labrum. You also have your glenohumeral ligaments, and these are all the ligaments that are on the bottom, the anterior middle part, and the top part. And you also have a joint capsule on the outside. So a capsule is a connective tissue that wraps all around the outside of the ligaments, all around the outside of the labrum, and that also stabilizes the joint. So this is a picture, guys, from the side. This is a sagittal view. So this is a parasagittal view. So you cut right here, and you're looking at it from the side, where you see the glenoid fossa. Above that, you see the supraspinatus tendon right here. So let me color this in. Supraspinatus tendon is this guy. That muscle is securing the glenohumeral joint. In the front, you have the subscapularis tendon right here. That also secures the glenohumeral joint. On the back, you have the teres minor, and you have the infraspinatus. You also have other structures. These ligaments here, bam, 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 are the ones I talked about right here. So you have your inferior glenohumeral ligament. You have your middle glenohumeral ligament right here. And you have your superior glenohumeral ligament there. And then around just that lip of the glenoid fossa, you have your labrum right here. And all of that together and what you find wrapping the whole outside of those ligaments and that labrum is the joint capsule, which is a big white tissue kind of wrapping the whole outside. So that's a dense connective tissue on the outside. And that's what stabilizes the joint. So know those ligaments, know kind of from front to back which muscles, which ligaments stabilize that joint. I think that is something I would quiz. Okay, guys, so two common pathologies, guys, of this joint. One is your glenohumeral joint dislocates often for many people. So dislocation, guys, is this bottom X-ray here. This humerus is basically, can you imagine which muscles and ligaments have been torn so that this humerus displaces this far? This is a dislocation. If someone dislocates their joint, that means that that bone is completely somewhere else. Those ligaments and muscles that normally stabilize the joint are ripped, torn, and this person is screaming on the floor. So that's a dislocation. This is a subluxation where you have a slight strain of a muscle, a slight sprain of a ligament, where this humerus, there's increased distance, but it's still in the joint. That's a subluxation. You'll see someone in a sling for many, many weeks, but this is mega repair of the joint, is a dislocation. Another one, guys, is a slap tear. I had a buddy in college, Colin Veldman. I'm going to show a picture of him. Colin, this is me with a bunch of our throwers at the Pac-10 meet my junior year. Colin was like 6'6", 6'7". He's this big, giant guy. He just loved to work out. He would work out 6 days a week, and he would go work out on his own the seventh day against coach's advice. And he would do a lot of upper body work. He had this biggest deltoid I've ever seen. He benched about 470 pounds. He was a big guy. He had a slap tear. So what a slap tear is a superior labrum tear, anterior to posterior, which means that this labrum, this cone of shame, this is the picture I was looking for earlier. This is this labrum that extends directly out from that glenoid fossa, just kind of lets that humeral head sit in a little bit more of a valley. Colin tore his labrum from like, I think it was like 3 o'clock to 9 o'clock, or it was the very top portion of the labrum. And so that was a slap tear, a tear to the labrum, superior labrum, anterior to posterior. Okay, so just recap of the lesson. I'm done. Here's the wrap again. We just looked today at the 4 humerus muscles, the rotator cuff that lock the humerus down. I would know these pathology types, so maybe create just a brief definition of each one. Number 1 being the hardest one, the most amount of information there. These being just really brief definition is fine. So don't think you have to master every one of these. Just know the structure, know how it's injured, know what a treatment type is. And I would review this stuff. I would review the origin, insertion, action of the 4 rotator cuff muscles. And that's all I got. Thanks, guys.